Thank you very much for the invitation. I was very welcome here. I was here last time back in 1971 when I was just out of my medical school, and Antalya was a very, very small place at that time. But I've been to Istanbul several times afterwards, and I'm glad to come here and see all these new buildings and new possibilities. I'll come back again if I have the chance. We are going to talk about the psychopathology in the perinatal period. Of course, there is a lot of things that should be said about this But one thing that must be kept in mind is that until a few years ago, talking about the perinatal period was talking about postnatal mood disorders according to this classification, where you had postpartum depression up to 12% of the population, and then you might have a postpartum psychosis, a very, very low number, and then you had a lot of what is called maternity blues or baby blues. 80% of the women after delivery would develop maternity blues, but that was not considered. It's still not considered a psychopathology. One thing that must be kept in mind, however, is the fact that whenever you have a maternity blues, there is a chance that approximately 20% of them will develop depression anyway. So it must be kept in mind. It's not really, you have to give an attention to this. You don't have to treat it. You just have to follow, the mother and see what happens afterwards. But this was one thing. And then you can see the studies about this area have been done in so many different ways with different methodologies, so that a first meta-analysis was done in 1996, so it wasn't too many years ago, but talking about postpartum depression mostly. Only 59 studies were considered for this meta-analysis, which means that there were a lot of studies going on, but only a few had the possibility of addressing the same psychopathology, the same kind of population, using the same kind of time frame, and the same type of instruments. EPDS has been one of the most commonly used at the perinatal depression scale and has still been used nowadays. But this was in the origin. And then in 2005, 2006, Gaines made a second meta-analysis. And in this case, something came up, which is finally they looked into the pregnancy period to consider also the psychopathology, not only the postpartum. And this is very important because for the first time you look in this part of the woman's life which has always been considered a happy moment. You couldn't be depressed because you were pregnant and you should be happy about being pregnant. But if you think about sadness, then sadness, you could say you cannot be sad during pregnancy. You should be happy because you are with child. But then if you talk about depression, depression is not sadness. Depression is a illness, and you can be ill even during pregnancy. This is the difference, and this is the important part of the studies. But again, as you can see, even in this meta-analysis, the problem was the same. Only about between 50 and 60 studies were considered because of the problems that we talked before. The number of subjects, the period, the time frame, the type of instruments. So going on, what we can say about the antenatal depression risk factors. One thing is that certainly the family psychiatric history is a risk factor, as well as a personal history of affective illness, but also some other social or socioeconomic risk factors like younger age, living alone, marital discord, inadequate psychosocial support, and so on. But one thing that is being considered also is the fact of being on antidepressant medication during this period. What does it mean? actually it means that if you stop the medication during the first period of the pregnancy, you raise the risk of having a new episode 5 times. So this is also an important thing. The thing that Giovanni Biggio was saying before about the fact that you may want or may not want to treat depression, it raises a question is if you are having an antidepressant medication and you become pregnant, should you stop the medication? According to the studies, you shouldn't, because you raise the risk 5 times to have a new episode after the withdrawal of the drug. And then, what is the risk actually of untreated maternal illness during pregnancy? First of all, is the unhealthy eating habits, poor weight gain, poor prenatal care. And then, if you worry about the fact that you should or you shouldn't give antidepressants, most of these people will get alcohol or drug as a self-medication. So we'll go over the problem and do things that may be harmful to their life and their child. Also, abortion is one possible outcome, and suicide. As far as suicide is concerned, well, while the number of suicide is is smaller than in other depressive episodes, it's also considered to be the leading cause of maternal morbidity, leading cause of maternal mortality in UK, probably also in Northern Europe. So this shouldn't be underestimated. Again, other things about the untreated depression. One is the poor pregnancy outcome, preeclampsia, placental abnormalities, low birth weight. This is also an important thing, because low birth weight has been associated with adult metabolic disease like cardiovascular, endocrine, and central nervous system diseases. So this is not something that should be underestimated again. Also, you find that you have children that are unconscious infants. They cry a lot. They seem to have what they call perhaps they are more sensitive to pain. When they go for the vaccination, they cry more than the others. And you can take either position. One is the possibility that there is a physical difference in these children, but also there could be also a psychological difference. They were not able to establish a good attachment with the mother because the mother was depressed, and they feel not safe in possible risky conditions. So this is also another thing that should be considered. And again, if you have a depression during pregnancy, you have a higher risk for postpartum depression. Going on, also, the fact of having a mother with depression can double a child's risk of also suffering from the disorder. But you would say, well, this is an old data, 2003. But there is a data, it just came out in October 2013, just a month ago, saying the same thing. And saying in the end that treating maternal depression antenatally could prevent offspring depression during adulthood. So this is also another thing. You may have that the result of having depression during pregnancy is also a possible cause of depression in the offspring of these mothers. So there are many things about this, and we have tried to assess the risk factor for perinatal depression in the study that we went on from the 3rd month of pregnancy to 1 year postpartum, using different instruments and following about a couple of thousand women for this period of time. And what happened, we found that the data is similar. You see the period prevalence is about 12%, which is the same as in the literature. Again, the postpartum is 9.6. And then if you go on, you'll find that the incidence of major depression and minor depression is, again, a little bit higher in the postpartum, but still similar to the literature data. And finally, one thing that is important is that you may have about 5.7% women who have their first episode during the postpartum period. They never had depression before. So this could be also considered as a possible risk of developing depression whenever you have a family history of depression or other things that we will see later on. But anyway, this is one reason why we found the fact that in the postpartum the number were a little bit lower in our compared to the literature, made us to start another study. And we decided to do one thing, just enroll women in the first months postpartum and enroll another group in the first month of pregnancy, then compare these two groups, the first month postpartum just enrolled and the one that were enrolled in the first month after the pregnancy, and they were followed during their pregnancy. And what we found was the thing that we suspected was the fact that if you follow someone during pregnancy, you reduce the depressive symptomatology and you reduce the anxious symptomatology. So that means that even if you do not treat them conventionally with drugs or even with a formal psychotherapy, the fact of providing a support or providing a reference person would reduce the anxiety and perhaps the depression. One thing that was important also was the fact that if you look at the risk factors, the only risk factor that remains in this group is the fact of having a history, a previous history of depression, which means that the others, the support from friends and life stress have been in some way reduced by the fact that they were able to talk with someone during their pregnancy. This is, I think, is an important thing to consider. Going on, I won't talk about the perinatal anxiety disorder because our colleague will talk about it later on, but what I wanted to say, just a few things again. Women with anxiety disorder during pregnancy were 2.6 times more likely to present postnatal high depression score. And what we did was the same thing. We tried to look into this in our sample. And what we found was that we had a lot of anxiety, lifetime and current anxiety disorder, especially panic. One thing that we thought about the fact that perhaps the people with panic are the ones who are more willing to come and being followed up in one study like this, which makes it a little bit biased sample. But anyway, we thought that it was an important thing because what we found was the fact that if you had anxiety disorder during pregnancy, you had higher risk of having minor or major depression or higher scores in the PDS, but also the fact of having a history of anxiety disorder, not only having it in pregnancy, but having it in a personal history also would increase the risk of the fact of having depression and or having depressive symptoms in the pregnancy and afterwards. One thing was that we found that panic was very important because the fact of having panic in the early phase of pregnancy increases 4 times the risk of having postpartum depression, but not only as a current disorder, but also as a past disorder, but also as a family history for panic. Panic seems to have a very important role in the risk possibility of having postpartum depression. And this is the summary of what we found was having at least one anxiety disorder is associated with postpartum depression. The role of specific anxiety in predicting response is biased by the outcome definition and timing of assessment, which is important. But then if you look at panic, then it goes on even if you take care of the outcome definition and timing of assessment. And also we have some false positive detected by Edinburgh Perinatal Depression, but this seems to be attributed to the fact that the Edinburgh Perinatal Depression scale is not only evaluating or assessing the depression, but also some anxiety symptoms. Going on and going to the end of my presentation, the puerperal psychosis is also important. Why it's important? Because it's the most severe, most risky condition that you can have after delivery. But then, if you look at the symptoms of postpartum psychosis, you will find there is a lot of overlapping with bipolar symptoms, and only 7.8% of these patients had first-rank symptoms like in schizophrenia. So when you do a research on the Cochrane and Medline and PubMed, and you put together postpartum psychosis, you find that there is a link between postpartum psychosis and bipolar disorder. Why do you want to say this? Because the fact is that despite the magnitude of the problem of bipolar disorder during the perinatal period, effective management of bipolar disorder for women during this life cycle phases is very limited. And you can see that pregnant women with bipolar disorder are highly vulnerable to recurrence without continued pharmacotherapy. The relapse rate is almost 100% among pregnant women with bipolar disorder discontinue mood stabilizer therapy. And also, you have found that there is this overlapping also with schizophrenia and with a sort of a bridge which might be called a schizoaffective disorder in this part in this condition. So this raises an ethical problem. Do you have to discontinue mood stabilizing in these patients? And I think that this is a very important question, because it is true that if you use valproate or if you use carbamazepine or if you use lithium, even if the data on lithium has been somewhat reconsidered recently, however, it is a very important thing. You must know, though, that teratogenicity of this drug is recognized, but also it is maybe 4 times or 5 times 1/10 or 1,000th of possibility. So it is important, but if you look at our colleague neurologists, they will never stop the medication for their epileptic women who get pregnant. So this makes it a little bit of a possible discussion in this area. Again, in the schizophrenic patients, one thing that is important is the fact that the maternal schizophrenia remains predictive to prematurity and postpartum psychosis. One thing that is important, though, is the fact that the best drug that you can use in this condition is the one that has the best classification from the FDA. It's in the B class, and it's clozapine. Clozapine is in the B. So it's supposed to be safe even during pregnancy, which makes, something that you have to take into account when you want to, cover this area of psychopathology. Again, one thing is talking about suicidality. What we did was the same thing. We tried to look into suicidality, not really suicide attempts. Fortunately, we didn't have any in our sample. What we found was, again, the fact that if you follow them from the beginning, let's say the suicidal thoughts or the possible suicidal thoughts sort of decrease along the way if you have a possible stable relation with a psychologist, a psychiatrist, someone who cares for you during this period, which might be very difficult. Again, and finally, this is our group and the publication. The screening is effective in identifying depression. Antepartum screening is the best strategy for identifying women at risk. Of course, the best thing would be the prenatal clinic. We have a specific group of people studying and accepting this, and we had established a very good relation with gynecologists, but most of all with midwives, which are the ones that follow the mother for the entire period. And also, it is important to think that depression is treatable and may not resolve without an adequate treatment. Sometimes if you don't treat depression, it goes on until 1 year after the delivery. So it's something that poses ethical problems, not as far as whether to give a drug or not because of teratogenicity, is whether you need to treat a person who is suffering from a very important disease. Catherine Wisner from Pittsburgh says, you worry about the toxicity of drugs, but you forget that depression is toxic in itself. So this is something that should be taken into account. This is our group and our site, and this is the group studying. Thank you.